Right. We'll start with the first questions of today's quiz. So the question is, mortality reviews are a critical element of risk management and quality improvement conducted to determine what? The options are: if the practitioners involved was or were appropriately licensed and credentialed. Option B, if treatments and patient care were adequate and appropriate. Option C, who was responsible for the mortality and what disciplinary actions need to be taken. Or option D, what the unit staff was doing at the time. If anyone can answer this.
Letter B.
Option B, if the treatment and patient care were adequate and appropriate. Yes. Sorry. This is the option B is the right answer. In a way, like the question was asking as to what the primary purpose of mortality review in risk management and quality improvement is. Right. So going by option to option, if the first option was like if the practitioner was appropriately licensed and credentialed. Look, credentialing and license verification is handled by medical staff services and HR and not in the mortality review, where mortality review focuses on the process of care that was given. It's not regarding the administrative staff qualification or anything, right? So option A is ruled out. And then option C, who was responsible for mortality and what disciplinary action needs to be taken? Look, this is a sort of dangerous distractor, right? It describes the punitive and blame-focused approach, which is very much quite opposite to CQ and what actually the mortality review philosophy stands for, right? We all know mortality reviews are non-punitive and systems-focused, right? They are designed to find process gaps and not to assign any blame to the individual. So option C is also ruled out. And option D, what the unit staff was doing at that time, in a way like this is a sort of surveillance or incident investigation behavior. This is not any sort of structured or systematic purpose of mortality review program. So this is also ruled out. So option B, if treatment and patient care were adequate and appropriate. This is a right answer, right? Because I mean, like when we question was the care provided clinically, was it adequate, appropriate, and timely? When we question that, we may come across were there any delays in the diagnosis or in the management of that particular patient, and was there any? I mean, like I think I mean the treatment was appropriate or not, or whether the clinical decisions were evidence based or not. All these things are discussed in the mortality review meeting, and never the individual blame is done. It's more of a system focused review meeting. So option B is the right answer. Now coming to the next question. So here the question is, healthcare purchasers and payers are demanding that providers demonstrate their ability to provide high quality patient care at fair prices. Okay. Here specifically, what are they seeking? Option A, objective evidence that hospitals and other healthcare organizations manage their costs well. Option B, current performance. Option C, baseline information. Or option D, objective evidence that hospitals and other healthcare organizations satisfy their customers and have desirable outcomes. What is the correct answer?
D.
D.
Option D.
Right. Right. So here the correct answer is option D. Why?
Object.
The question was like, in a way, like it was simple. it's describing a scenario where the purchasers and payers or the insurance company or something is demanding proof of quality care. What is the proof that the hospital or a healthcare organization is providing quality care? What do they want to see, right? So here, first option, when we see this objective evidence that hospitals and other healthcare organizations are managing their costs well, here the focus is entirely on the cost, right? So I mean, like here the outcome is not spoken about. Payers want both quality, value, so the outcome is also looked into, as well as the cost factor. So option A is ruled out. Now, reviewing current performance, look, this is vague. Like, what do they look into current performance, right? Current performance of what? There's no specific answer of what they are seeking from the providers. So it's too general, right? So this is not the right answer. Baseline information. I mean, like baseline data is the starting point for measurement, right? Baseline information is a QI tool. They can't demand something that vague. So this is also ruled out. Now, they are supposed to look into objective evidence that hospitals and other healthcare organizations are satisfying the customers and have desirable outcomes along with the cost factor. So option D is a right answer. So how do we actually collect what's the objective evidence of healthcare organizations of how do they capture the customer satisfaction? That's through feedback and HCAHPS patient satisfaction scores. That's a little broader one. Okay, and they'll also look into the readmission rates and infection rates, etc. also to see how desirable the outcomes were. Fine. Coming to the next question. A healthcare facility has committed to improving the overall quality of care for patients and their families during their stay at the facility. Among these goals, an improved quality of care are the goal of increased safety, better nutrition, and staff friendliness. The role of the CPHQ in improving quality of care includes all of the following except, right? So option A, providing each department of the facility with friendly reminders about patient safety. Option B, creating a disciplinary process for staff members who fail to treat patients in a friendly way. Option C, researching and providing the facility with different options to improve food choices. And option D, developing an educational program to help staff members interact appropriately with patients. What's the right answer?
B.
B.
I see everyone's answering B. Okay, right. Okay, so B is the right answer. Why and how? Let's see. It's asking another one important thing for you to remember is read the questions clearly. So these are the keywords that we are supposed to really not overlook as far as the exam is concerned, right? So here what it's saying is, what in a way, like in simple terms, it's asking what are I mean, like as a CPHQ, what are your responsibilities or what's not your responsibilities in the following four options. In that way, what's the role of a CPHQ, right? So except is a keyword here. Just in a way, like remember this. We all know that CPHQ, as a CPHQ, you will be a facilitator, educator, researcher, coach, a sort of support structure for the quality initiatives and everything. But you're not the leader per se. The ultimate responsibility or enforcement is not in your hands, and also there is nothing to do with sort of HR functions for you, right? So you do not have HR authority with you. So Talking of that, providing each department of the facility with friendly reminders about patient safety. Yes, I mean, like this fits perfectly with what the responsibilities of a CPHQ is, because you'll have to communicate quality and safety information to all the departments in order to raise awareness, and also it's a communication task for you, right? Now, option B is the right one, where I will be talking the last. Option C of researching and providing the facility with different options to improve the food menu. In a way, like this looks more of a dietitian's job, nutritionist job. But look, here CPHQ researches evidence and improvement options, because better nutrition, better nutrition is also a sort of facility goal, right? So in a way, like this is a sort of support for quality improvement in the dietetics section. So that's absolutely fine. Now, coming to option D, developing an educational program to help staff members interact. Yes, education and training are your responsibilities as a CPHQ. So there's nothing wrong with this statement as well. When it's asking about accept, so that would be a negative statement. Creating a disciplinary process for staff members. That's not CPHQ job, right? It's more of a HR and management function. Your responsibility is to support the staff. Your responsibility is to coach and teach them, improve them, but never to punish individuals, right? This is more of a HR's job. So the correct answer is option B. Now, coming to the next question. The CPHQ must integrate quality findings into governance and management activities too. Right? Options: align payment or incentive systems, tying rewards to clinical objectives to improve care. Option B, maintain the current governing system to provide a continuum of care. Option C, establish administrative policies and procedures for governance and management. Option D, rewrite the bylaws to reflect current streams of data inclusion. In a way, it's asking like, okay, right. Someone's answered option C is the one. So
A.
in short, it's A. Okay. There's a division, sort of, there's no unanimous decision on the answer here. So the question is asking like, why must the CPHQ integrate quality finding into governance and management activities? Like, what's the purpose of bringing quality data to the leadership or to the boardroom, right? So here, when we look into all the options, let's go with option A. Align payment or incentive systems tying rewards to clinical objectives to improve care. See, this is very specific about why governance integration matters. Here, aligning how people are rewarded with quality and clinical outcomes is important. In value-based care, it's a sort of incentivizing people for doing something good, right? So this is a strong possibility of being a right answer. Now, option B, maintain the current governing system to provide a continuum of care. Maintaining the current system? No, because the entire point of integrating quality findings is to improve. So maintaining the current governing system doesn't stand a chance. So this is not the right option. Now, establishing administrative protocols and procedures for governance. In a way, like policies and procedures are output of governance, a sort of administrative reason. But for us, remember, something regarding bylaws, administrative policies and procedures, this is a mechanism, but that's not a purpose. So this is a mechanism of integrating, but not a purpose. So here it's asking what's the purpose of integrating the quality findings. So this is not. Again, option D, rewrite the bylaws to reflect current stream of data inclusion. Like this could happen, but it's not the primary reason why the data is presented or data is sent up, right? So rewrite the bylaws to reflect current streams of data inclusion is also too narrow. The right option is align payment or incentive systems tying rewards to clinical objectives for better care and for improvement. So the answer is option A. Now, coming to the next question. Here, in healthcare organization, the quality department developed an indicator to measure the commitment of staff to myocardial infarction guidelines. This indicator measures what? Is it a process? Does it measure process, structure, culture, or outcome?
Process.
Process. Right. So the correct answer is option A, process. In a way, like the question was simply asking, what is the staff's commitment to myocardial infarction guidelines is? We all know Donabedian framework of structure, process, and outcome, right? So here, having all the resources is structure, staff doing certain things and commitment is a process, and the end results are the outcome measures, right? So here the process measures what is done, whether a sort of evidence-based practices were followed or not, whether the clinical pathways were followed or not. The commitment to MI guidelines means the staff is following the MI protocol, right? So this is the right answer. Is it a structure? Look, structure is what you have. Commitment to guidelines is not having resources. Having the guidelines or having the pathway is the structure. If the question would have been like, was there any guideline for myocardial infarction management, then it would have been the structure. But here the commitment of the staff to MI guidelines is being asked. So it's a measure of process, right? So culture, it doesn't fit into Donabedian framework. And then outcome, in a way, like if it was regarding myocardial infarction, MI mortality rate, or if it talked about readmission rate for MI patients within 30 days, then it would have been outcome. But here in this case, it's not the right answer. So the right answer is it's a process indicator. Now, coming to question number 62. All of the following are ways through which any organization leadership can enhance the spread of quality culture within the organization, except option A, develop mission and vision statements, assign quality professionals to lead the process of cultural transformation, adopt flexible management styles, or develop quality initiatives.
B. Assign
B,
quality
assign.
professionals.
Okay. So everyone's answering B. Right. Let's see. Here, what was the question? The question asked which option is not a valid way of leadership to enhance the quality culture, right? So not, except is the keyword. Develop mission and vision statements. We know, like having the mission and vision is a foundational leadership action for quality culture. So developing a mission and vision is a way of enhancing or the spread of quality culture. So this is a right statement, but here except. So we are looking for a negative statement, right? Okay. Now coming to option B, cultural transformation. It's talking about assigning quality professionals to lead the process of cultural transformation. See, cultural transformation must be owned and modeled by the leadership itself. The top leadership is responsible for leading any cultural transformation. It is not delegated. Here, quality professions can't lead this, right? Leaders define and influence organization culture. Okay, so this is something which is not related to the quality professional who are here. So by this, by asking the quality professional to lead the process of cultural transformation, they can't spread the quality culture, right? Option C, adopt flexible management styles. Yes, in a way like transformational and flexible leadership style often go positively with quality culture. Okay. So this is also the correct statement. Develop quality initiatives. Yes, creating quality initiatives is a leadership commitment to quality. Okay. So this is also right statement. So the right answer is option B, assign quality professionals to lead process of cultural transformation. Now, coming to the next question. Evidence-based quality management promotes what? Option A, culture of excellence, culture of free from medical and medication errors, culture of cooperation, or culture of no punishment.
Letter B.
Culture of excellence.
Culture of excellence. Okay.
Culture of medical and medical errors.
Someone's answering is option B. Okay. Right. So the question is, evidence-based quality management, EBQM, specifically promotes what? Okay. So here, coming to option A, EBQM, what does evidence-based quality management do? Evidence-based quality management, we all saw in the last session that is the integration of scientific evidence and methods into quality improvement processes. Okay. So in a way like when an organization commits to making decisions or designing the process and improving the care based on the best available evidence, the result is the culture of excellence. Okay, so best of the available evidence is taken. That leads to the culture of excellence. So the most probable right answer is option A, culture of excellence. Then why not option B, like how someone told? See, error elimination is an outcome of quality culture, right? Here the question is, the key word is promotes. Culture of free from medical and medication errors is a sort of outcome of quality culture and not what the EVQM promotes. Okay, so it's more towards the just culture and safety culture. Okay, not EBQM. Culture of cooperation, right? Cooperation, teamwork are important, but here it's specifically this question is about evidence-based quality management. Okay, right. Culture of no punishment. Yes, this is also regarding the safety culture and just culture. So the correct answer is option A, culture of excellence. Whenever EBQM is asked, promotes, it's the culture of excellence. Okay, leadership commitment to a culture of excellence, not perfection, culture of patient safety and ethics. Now, coming to the next question. Here it's asking, like during a surgical procedure, a small medical implement or in a sort of there's a sort of typo over here, a medical equipment was or a medical implant was left inside a patient. The follow-up surgery here, again there's a typo, the follow-up surgery to remove the equipment is an example of what? Is it quality improvement? Is it quality control? Or is it quality assurance? Or is it total quality?
Quality assurance, policy and procedure involved.
So
A.
is a
Quality
quality
improvement.
assurance? Okay. So in a way like this is a sort of quality assurance versus quality control versus QI versus QKM. Here the question is like giving a specific clinical scenario, a retained surgical instrument that is discovered after surgery. During the surgical procedure, a small medical equipment was left inside a patient. The follow-up surgery, here the key is the follow-up surgery to remove the equipment is an example of what? Okay. So in a way like remember, what is quality improvement? Okay. So we all know quality improvement means it's a systematic proactive effort to improve the process over time. That is having PDCA cycles, data analysis, redesign. In this given scenario, it is not a planned improvement initiative. It's more of a reactive one because there was an equipment left inside the patient. Immediate reaction or a sort of the reactive effort is being done. A resurgery is being done. Follow-up surgery is being done to remove that particular equipment. So that is not a planned one, right? So quality improvement definition doesn't fit into it. Now, quality control. See, quality control involves detecting the errors and taking immediate corrective actions, right? So once these errors are detected, immediate corrective actions are taken in order to fix them at the point of occurrence itself. So here there is an equipment that is retained. So there was a sort of non-conformity. There is an error. So the follow-up surgery is the immediate correction to eliminate that specific error in that particular patient. So quality control definition does fit this scenario. Now coming to quality assurance, why in a way like quality assurance is also a systemic and planned activity designed to prevent the defects from occurring. Right. In a way, like think about this. If at all, what do you say? Before the error reaches the patient, like when you have what do you say? WHO surgical safety checklist. Having WHO surgical safety checklist is more of a quality assurance thing, right? So here this is not a preventive aspect. This is after the error has been done. So quality assurance is also not the right way to go forward. TQM, see, we all know TQM is a holistic organizational philosophy, right? So it's not a specific reactive action. Okay. So even this option is not right. I hope you all understood what exactly this is talking about, right? This is more of a reactive one. That's the reason here I have underlined this particular thing. The reactive step immediately after an error is a quality control thing, not a quality assurance, not a quality improvement or TQM. Okay. Now, the most effective role of healthcare quality professional as a facilitator of change to quality culture in the organization is what? Is it education of leaders, education of staff, evaluation of performance, or designing the processes? What is the most effective role of a healthcare quality professional as a facilitator of change?
B.
Someone's saying B. Okay.
A.
Right. Yes. Someone told me A. Okay. So we all know leaders actually play a very important role in bringing out establishing and spread of quality culture, right? We all know once the leadership commitment is there, then everything has a cascade effects. One educated leader influences the behavior of the entire team. So the right answer is option A, the education of leaders, right? So this is the most effective. Here he asking most effective role as a facilitator of change. Okay, so that's the most effective role as a facilitator of change. These are the keywords for this particular thing. And why not option B? Look, staff education is important. It's essential. It's valuable. It builds operational competency. Okay, but it is less effective than educating a leader for culture change, because if we educate the staff but still the leader is not committed and is not educated regarding the quality culture, then sorry to say the culture of the quality culture doesn't spread, is not promoted at all, right? So option A is far important than option B here, right? Evaluating the performance, it's an important function, but it doesn't drive the cultural transformation. Okay. And designing processes, well, it changes the workflows, but it can't influence the values and mindsets, right? So here it's asking regarding the quality culture. So designing process doesn't actually help anything in that. Next question. Best to ensure success of quality improvement in the organization. Best to ensure the success of quality improvement in the organization. Education level of, I mean, like it's asking what is what best ensures in a way, like let me rephrase that. There's a, I mean, like the question lost in sort of translation, it seems. What best ensures the success of quality improvement in an organization? Is it option A, education level of quality leaders, or people skills of facility leaders, or the culture of organization?
Culture of the organization. C.
Culture,
You see?
right? Culture of the
People
organization,
skills
right?
of processing.
Okay. So the right answer is the culture of organization actually ensures the success of quality improvement. How? Because culture is foundational, okay, in which quality improvement either succeeds or fails. So cultural alignment improves quality improvement engagement, and hence will lead to effective implementation and also sustainability, right? I mean, like even the best educated, most skilled people are available, but if the culture doesn't support, if culture resists change, if the culture punishes the reporting or lacks any sort of shared quality value, then everything is lost. So the culture of organization is the best ensurer of success of QI. Okay. Now coming to the next question. The performance indicator total unscheduled inpatient readmissions within 48 hours is a measure of what? Is it a structure? Is it a process? Is it an outcome or process and outcome?
Outcome. C.
Right.
Letter
The
D,
correct.
processing income.
Okay, someone's talking about process and outcome as well. But let me tell you, option C, outcome indicator is the right answer. Let's see. It's asking total unscheduled inpatient readmission rate. I mean, like, this is not planned. The patients were cared for, they were discharged, and then the discharged patients got admitted again because they were not cared for properly. So here we are talking about the outcomes, the result. Okay, so outcomes is the right answer. Then why process and outcome is not the right one? Because as we all know, Donabedian framework talks about structure, process, and outcome. All three are distinct and causally related. There's nothing like process and an outcome. Okay, so in a way, like this is more of a distractor. This is more of a distractor. There's nothing to do with two. It can't be both. It can't be process and an outcome. Okay. Next question. The number of designated women receiving breast cancer screening or in a way like mammograms in the reporting year measures what? Is it a process, clinical outcome, process outcome, or process and clinical outcome?
Process outcome.
Letter D, process and clinical outcome.
Someone's talking, it's a process outcome. Someone's talking process and clinical outcome. See, I've told you earlier also, these are all the distractors. We have discussed ample number of
Yes.
times regarding the structure, process, and outcome. Whenever there is a measure or sort of indicator question is asked, remember only three things. It will either be a structure or a process or an outcome. It can't be both structure and a process. It can't be both process and an outcome or structure and a outcome. So all these things will be a sort of distractors for you. Okay. Here is talking about the number of designated women receiving breast cancer. We all know what is a structure. It's more about the facilities that we generally have. Whether the mammogram facility was available there or not comes under the sort of structure. Whether the available time, the proper sort of appointment time is available for the patients to undergo the screening is also a structure. But what is being done to the patient, what clinical actions that were done for the patients or to the patients always is a process. Okay, so here mammogram screening is a preventive clinical action, okay, performed on eligible women here. So here measuring how many women received it measures whether the evidence-based care was done or not. So it's a process. It's a process indicator, right? So clinical outcome, see here it's not talking about the patient, the woman getting breast cancer or not, right? Process outcome, again a distractor. Process and clinical outcome is also a sort of distractor for you. Okay. So the correct answer is the process. And let me tell you again, we have discussed this already. You can refer to the handout of the last session as to what constitutes the structure, what constitutes the process, and what constitutes the outcome. Outcomes is always the result. The rates which we talk is always infection, I mean like hospital-acquired infections, the readmission rates, the satisfaction scores, everything is an outcome measure. What is done to the patient or for the patient is always the process. Whether evidence-based guidelines were followed or not is also a process. Whether the policies were present, whether the pathways were present, whether the staff was present, whether the equipment was present, whether the facility were present, whether the appointment was available or not, everything comes under structure. So I hope everyone understood this particular concept. Okay. Now, coming to the next question, measuring the time it takes a nurse to perform a procedure addresses which of the following aspects of care? Is it monitoring? Is it process? Is it outcome or a structure?
Process.
Right. Again, here, the time it takes a nurse to perform a procedure, again, it's what's being done. What's being done here, the action is being measured, right? So the correct answer is it's a process. Okay. Outcome would have been like what happened to the patient after the care, whether there any complications were there, whether there any mortality was there or not. Okay. If the staff were present or not would have been the structure. Monitoring never comes in the Donabedian framework. Coming to the next question, the number of productive hours worked by nursing staff with direct patient care responsibility per patient day is what?
Structure measure.
Structural.
Right. Here, right. It's a structural measure, like how I told, whether the staff were present or not. What's the availability of the staff was there or not? Availability of equipment was there or not? Everything here, the nurse was available for X number of productive hours, right? So in a way like that's a structural measure. So good. Now coming to the next question, question number 71. One of the aims in the treatment of severe community acquired pneumonia is to maintain an oxygen saturation of about 94%. Ensuring adequate oxygenation in this condition is what?
Process measure.
Process measure. Yes. Here, simple. One of the aims of treatment is here the aims of treatment of community acquired pneumonia is to maintain the oxygen saturation of above 94%. Yes. Here, ensuring is the key. Ensuring, the term ensuring adequate oxygenation. Ensuring means the nurse is making sure that the saturation level remains above 94%. Here she is doing something. This is a clinical action being performed, right? So that itself will say that it's a process measure, right? I hope there's no sort of confusion regarding this. Availability of oxygen, availability of nurse would have been a structural measure. Now, a complication arising out of the treatment given would have been the outcome measure. Okay. Now, coming to the next question. In an improvement project to reduce the wait times in an emergency room, the time taken to be assessed by a physician is what?
Still a process measure.
Process.
Right. So
Right.
here,
Yes.
again, to reduce the waiting times in an emergency room, the time taken to be assessed by a physician is here. It's the action involving the patient care, right? It measures how clinical care is delivered, including the timeliness. So this is a process measure. Okay, good. I mean, like, you're doing good regarding this Donner-Bedient framework and SPO indicators. Now, in implementing a care bundle for the management of acute MI, the recording of the extent to which smoking cessation counseling is provided is a measure of what?
Recording process.
Outcome process.
Still process.
Okay, right. The correct answer is process itself. How? Why is it not a structure? I mean, like, look, smoking cessation counseling, the policy or procedure regarding the smoking cessation counseling, if it is available, then it is a structural measure, right? The pathway or the fields of counseling in a form, recording that, whether the counseling was given or not, recording is also a sort of patient care process. So here it's a process thing. Whether the patients were given the counseling, but yet how many patients stuck to it or did not stick to it, or if the patient had any sort of myocardial infarction even after stopping undergoing the counseling and smoking cessation, would be an outcome measure. So the correct answer is the process. Good. Recording, keyword is the process. Now, coming to the next question. While deploying a CQI team, which issue needs to be first approached? Okay, deploying a CQI team would be first approach in addressing which one? Or let me rephrase, while deploying a CQI team, which issue needs to be first approached or prioritized? Here, this question is asking regarding the prioritization. There are 4 statements. There are 4 problems. Before you start the quality project, okay, out of these 4, which one will you prioritize first?
A.
A.
So the options given are: several patients complained their call lights not answered during night shifts. Option B, several physicians don't allocate enough time for procedures which while booking surgical cases. Option C, finance billing outpatient procedures as ambulatory surgery. Option D, results of pre-admission testing for inpatient survey are unavailable for 35% of the times, causing delay. So what was your answer?
A.
A.
Right. Option A. See, why A is the right answer? Okay. So their call lights not answered during night shift. So call lights means in a way like it's a sort of the bell or sort of the patient wants the nurse to be attended. the patient wants to be attended by the nurse at that particular time in the night shift, right? So this is a patient safety issue. If the call lights were not answered, I mean, like the patients may not be assisted. That may lead to falls or serious injury or even death, right? So delayed response in this means that's a threat to the patient safety itself. So patient safety issues are always the highest priority. Remember that. Okay, so coming to option B, several physicians don't allocate enough time. So this is more of an efficiency and scheduling problem that could affect the quality of surgical care, but it is not an immediate or active safety threat. Okay, so this can be looked after later when compared to the first option. Coming to option C, finance billing, outpatient procedures or ambulatory surgery. So this is more of a billing issue. So it will be serious in terms of regulatory and financial aspects, but it doesn't directly threaten the patient safety right now. So even I'm not going to prioritize option C. Coming to option D, so pre-admission testing results unavailable 35% of the time, causing delays. Yes, 35% unavailability rate is concerning. It definitely requires attention, but it causes delays. It is causing delay, but it's not an immediate direct patient safety issue, or it's not immediately causing direct patient harm at this particular point. So when I try to prioritize, option A is the most important aspect which I should be looking into, right? So in a way, like that's the first thing I'll be looking into, right? So remember, patient safety is always first. Okay, only then you'll have to move on for other activities. Let me tell you this. This was in a way, like during my exam, this was one of the questions that I received. An ambulatory outpatient care facility identifies an opportunity to improve the turnaround time for reports of X-rays performed at a local hospital. Okay. Which of the following groups should be involved in the team to improve the process? Option A, administrative representatives from both facilities. Option B, primary care physician, clinic nurse, and clinic administrator. Option C, clerical, clinical, and administrative staff from both facilities, or only a radiologist, primary care physician, and clinical medical records. What's the right answer?
C.
C.
Both facilities.
Okay, right. So it's asking an outpatient facility is targeting to improve their turnaround time for X-rays, but they do not have X-ray facility at their facility, so they are referring that patients to a local hospital. Okay, in order to decrease the turnaround time, who should be involved? Remember, involvement in such activities should be from the end users, or the people who are involved in the entire process. So here, coming to administrative representatives from both facilities, it's a narrow one. Administrative representatives alone can't exactly reduce the turnaround time. Primary care physician, clinic nurse, and clinic administrator is only talking about one side of the care. They are not involving the local hospital or the radiology department of the local hospital where actually the X-rays are being done. So option B also is a sort of narrow one. Option D, radiologist, primary care physician, and clinic medical records, okay to an extent, but again here the non-clinical and clerical staff of both facilities are being not included. Here the clerical, clinical, and administrative staff from both facilities are supposed to be involved. Okay, so option C is the right answer. Coming to the 76th question, the best indicator used by ambulatory setting to measure its outcome is number of admissions to the hospital, number of surgeries, claims data, or number of dispensed drugs.
Number of admissions to hospital.
Number of admissions to hospital. A, right. Can you tell what? Right. Okay. So here it's talking about What's the best indicator? What's the best indicator used by an OP setting to measure its outcome? In a way, like it's asking what is the outcome measure or outcome measure wherein the performance of the clinic is being measured, is used to measure. You see, for OP setting, the patients come in, they get treated, they go back to their homes. They're not admitted. If the care that was given was appropriate and adequate, then there would be no need for admission or hospitalization. Or if we start tracking after taking the care within an OP setting, how many patients are actually being treated well, or if being prevented from hospitalization, then that gives a better performance criteria for that particular ambulatory setting, right? So if the hospital is providing high quality preventive and chronic disease management well, and I mean, like, without any sort of further escalation, then that's a good thing. In case if the numbers of admissions to the hospital are high despite taking the treatment from that OP center, then that gives a impression that the care was not adequate. Okay, so it's the right answer. Number of surgeries, look, that depends on the condition. So it's a utilization or volume measure rather. So it doesn't tell you how good the facility was doing in their primary sort of job, right? Claims data, again, this is a sort of administrative data source, nothing to do with the measuring the outcome of the OPD. Number of dispensed drugs, again, it's a utilization measure, so nothing to do with this. So the correct answer is number of admissions to the hospital is the best outcome measure for an ambulatory setting. So with that, we finish our quiz for the quality basics. I mean, like, do you have any questions